through the tissues as a cone and focuses at a point approximately 5 to 6 centimeters deep inside the tissues. Now that is a fixed focal length, and so you may think, how do we know exactly where that focal point is going to hit, and how can we aim it onto the vein? Well, the answer to that is this whole head is surrounded by a balloon here, which is filled by a pump with cool fluid to keep the skin cool, but also at a certain pressure, this holds the tissue a certain distance away from the transducers, both the imaging transducer and the treatment transducer. Now, by changing the pressure of that, we can do all sorts of things. We can actually move the vein closer or further away. We can, of course, move the robot arm as well. But when we want to treat the vein, we can also reduce the pressure, first of all, to see the vein, and that will allow the vein to open. And then when we want to treat the vein, we can increase the pressure, we can force that vein to shut, so there's no blood flow in it, and all the heat that is then formed by the high-intensity focused ultrasound is concentrated in the vein wall. And we'll see a video of this shortly. So this is a simple diagrammatic view of that treatment head. And here we're seeing the two-dimensional grayscale ultrasound here. And with the Sonovane 1, we used to have to put this local anesthetic targeted around the vein. And this is a typical sort of thing that we were seeing back with Sonovane 1 in 2019. When the grayscale had to image the vein and we were certain we knew exactly the point we had to treat, we were then able to fire this domed array, and this would give a cone of high-intensity focused ultrasound focused at this one point where we would get the ablation and the thermal effect of the ultrasound. The result of this was then to see gas bubbles from the ablated tissue, and this is called the hyperechoic marker, but it's actually little gas bubbles within the tissue, within the vein itself, showing that we've elevated the temperature of the vein and will cause destruction of the tissue. This is you can see this focus vein, 89 probe. Treatment vein. Okay, pulse in the blood comes so you got food working with anything. How's that feel? With that original Sonovane 1 machine, it took 1 minute per pulse, and that was 8 seconds or 4 seconds to actually have the heating effect, but then a cooling time of approximately 40 seconds, which really made it a very laborious and slow treatment. So although Sonovane 1 did work and the pulses were effective, and as we presented previously, we got good ablation rates of the veins we treated, it was so slow it wasn't really a viable treatment for any but the most special patients who really wanted to have it done or had the most minor disease. So Theraclean then brought out Sonovane S, a much more speedy way of performing Sonovane, hence the S for speed. The major difference was that the pulses were 0.5 seconds or 1 second in duration, with a cooling time of 6 to 8 seconds, which meant that each pulse went from being a minute to only 6 to 8 seconds. So instead of doing 1 pulse per minute and still looking for the vein, we were able to perform 5 or 6 pulses per minute. This was a tremendous increase in speed of treatment. This is a S action hit 1 pulse coming, and then you see how big the pulse is going to come. You can see that's the target vein, but it's targeted looking anesthetic around it. There's another pulse coming, and you can see how quick not only the pulse comes, but also how quick this cooling effect happens, allowing the second pulse to come straight afterwards. So this was clearly a much faster technique with the Sonovane S, although we were still using some form of injected anesthesia around the vein for most patients at that stage. So in August this year, we took delivery of the latest version of Sonovane, which is Sonovane HD. And this really is a huge advantage over the previous Sonovane 1 and even the Sonovane S. And I'll run through this briefly now. With the Sonovane HD, we get far better imaging. The imaging is much better, both grayscale and color scale, so that we can actually see everything we're looking at with much more clarity. More importantly, we don't have to change over from one probe to another. Physically, there's a software changeover, so you can go from treatment head to diagnostic probe and back again. We found we can preload our patients with oral non-steroidal anti-inflammatory, one called Nefapam. And if we do that about 20 minutes before treatment, very, very few of those patients need any local anesthetic at all. So most are now having treatment of truncal veins or perforators with no local anesthetic injections whatsoever. Those that do need it don't need targeted local anesthetic anymore, but we do a very, very small amount of peri-adventitial anesthesia, so little that you can't even see it on the ultrasound once it's diffused within a couple of seconds. This is a compilation video looking first of all at taking the pressure off the balloon, and you can see in the middle here the great saphenous vein opening. Putting the pressure back on, we can see the vein closing again, getting all of the blood out of the area, and then we can treat the vein wall with a half-second pulse. And 2 or 3 of those will start closing that vein so that we can then start working down the vein itself. You can actually see not only the HEM, the hyperechoic marker, but if you saw very quickly, you can even watch the tissue contract, and you can see the effect of the closure of these perforators. So with a high definition ultrasound, we can see the perforators so clearly. We can use color flow to see flow in them. We can then treat them with about 6 to 8 pulses, and straight afterwards we can see that they're occluded. So incompetent perforating veins are very, very accurately treated and very quickly, with no need for scrubbing up or introducing any needles into the veins at all. We're also now treating really quite complex neovascular tissue, particularly in the groin, where people have had previous open surgery. And we can see all the different vessels in the groin. And by starting with a HIFU and starting at the saphenofemoral junction, or wherever the leak is coming from where the tie had been, and working our way outwards along each of the vessels, we can get a very good thermal ablation and closure without doing any incision into this area, without disturbing it, and in many cases with minimal, if any, local anesthetic at all. So this really is an ideal way to treat what is otherwise quite a hostile groin with a lot of scar tissue. So, Mr. Chairman, ladies and gentlemen, in summary, high-intensity focused ultrasound is thermal ablation. We're heating the tissue at the specific point, and we know we're heating it to a level that is going to kill the cells and cause thermal ablation without any carbonization. So, although it's not endovenous, it's not within the vein itself, we know the principles of thermal ablation work, provided we get the right amount of energy into the right volume of vein. So, we're on a good starting point to have an effective technique. When we then look at anesthesia, most of the patients with the Sonovane HD and even with the S now don't need local anesthetic at all. Those that do, it's very easy to inject under the cold balloon, and patients don't really feel it very much, particularly if you use a very small needle, like an orange or 29 gauge needle. Nowadays, we only use a very small amount of concentrated 1% or 2% local anesthetic, and we just inject a very small volume peri-adventitially. And this allows the vein to stay open, and it allows us to use the different tricks of either using color flow or to squash the vein to see it wink or open and close with the pressure, so we can identify the vein and see when it's eventually ablated. We've already found that when we look at timings of getting patients into theatre, out of theatre, scrubbed up, etc., we're finding equivalence between endovenous surgery and Sonovane, which of course does not need any of that preparation. So therefore, Sonovane is at least as quick, if not quicker, for the treatment of incompetent perforating veins and for neovascular tissue in the groin. Without doubt, it is still slower for isolated truncal vein ablation due to the length of vein that needs to be ablated. And without doubt, once you get over about 5 to 6 centimeters, then the Sonovane is much slower because you have to go along hitting each individual point of the vein at the way we're doing it at present. However, it must be said that the speed is improving considerably, as I've already shown you, and there are some new developments coming which is going to speed it up even more. So in conclusion, Mr. Chairman, ladies and gentlemen, high-intensity focused ultrasound is definitely easy and effective and probably the selection of choice at the moment when treating varicose veins, secondary to incompetent perforating veins and neovascular tissue. It is effective but takes longer than the endovenous thermal ablation techniques. When we look at truncal veins, if a section needs treatment more than about 5 to 6 centimeters. Less than that, there's an advantage to the high-intensity focused ultrasound, as you don't need theatre, you're not being invasive, and patients can still wear their outside clothes, and this can be performed in an outpatient room without need for any sterility at all. However, because of the speed of the thermal ablation devices, once they're in the vein, once you get over 5 to 6 centimeters at the current time, the high-intensity focused ultrasound starts taking longer and longer, the longer the vein is. However, having said that, things are moving and we are increasing the methods to increase the speed of treatment. More importantly, it is a walk-in, walk-out technique with no needles, nothing inside the vein. And certainly in this time when patients are very worried about infections and things being both in the body, but more importantly in their vascular tree, we're finding more and more patients are now coming and saying, I accept a higher price, I accept maybe more treatments and more time to come treatment and certainly longer treatments, provided I can have something that's totally non-invasive. So I think we're going to start finding that HIFU becomes the patient choice for the treatment of varicose veins. Thank you.
Thank you. This is a recorded video of this interesting and we shall move for the talk of the venous congestion. This talk is delivered by Professor Svp Classification. Svp Classification is a professor of venous surgery at the University Ankara, Turkey. Also is the secretary of Turkish Society of Neurology. Professor Classification.
Thank you very much. First of all, also, I want to thank Dr. Ayman Fakhri for inviting me. And it's our pleasure to be with you today. And I think as a title, pelvic congestion syndrome is a very huge topic to talk in 10 minutes. But I will try to summarize it as much as possible. And we are already very late, nearly more than 30 minutes. So I have to be as quick as possible. All we know that the pelvic venous disorder is a really poorly understood and frequently misdiagnosed disorders of the pelvic venous problems. And it's a very potential cause of chronic pelvic pain in women of childbearing age. And it is defined as intermittent or constant pain of at least 3 or 6 months of duration localized in the abdomen and pelvis. It is not limited to any period of menstrual cycle or intercourse and not associated with pregnancy, although we observe it more people with pregnancies. It's very common. And if you look at it, approximately 10 to 20% of gynecologic consultations, only 40% of them with CPB have ever referred to a specialist. And there are lots of differential diagnoses, which I will not mention about it, but we have to know that this is a situation that needs to be treated with a multidisciplinary team approach. Because of the lack of standard diagnostic criteria, we are underestimating or underdiagnosing this pathology. When we look at the disease spectrum, we see that if it is related with reflux, or if it is related with an obstruction, or it's a pelvic malformation. I think the reflux part can be above the pelvic escape points or below that. Or if it is an obstruction, either it's an endoluminal obstruction like post-thrombotic problems or extraluminal problems, which can be called as dynamic compressions of renal vein and the iliac vein, and also static compressions extraluminal. So we have to, I think, take into consideration all those pathologies when we are approaching a patient with pelvic problems. And as we know that we have an Svp classification, which has been also published in 2021. With many of our colleagues, it has been accepted as cumbersome, but if we use the, let's say, app from App Store or the Google Store, it's very easy. That I'm mostly using it now from the app. It's easy to use it. You can download it easily, apply to your patients. And I think for the future collaborations and for the future research projects, as we also use the Svp classifications for the varicose vein, we need to, I think, ourselves to use those classification. And one of the most important things, I think, having those type of patient awareness programs to increase the awareness of this disease, because many of our patients, even or some parts of gynecologists, even doesn't know anything about the venous pathology, which may cause a problem in the abdomen or pelvis, which is, I think, very important. Through with, I think, social media or with other type of, let's say, information channels, we have to improve the patient's awareness to increase our referrals. And when we come to the treatments of method, we know that I think there are not too many guidelines related with this one. And the latest ESVS guideline, we have that, but just I don't want to go all the details of this flow chart. But what I want to show you is whatever the recommendation, if you look other than the diagnostic parts, they are or low level of evidence, because we don't have a good, let's say, randomized controlled trials which will guide us. I think just because of it, as Dr. Kavezi also mentioned in his presentation, we should start from the fundamentals, really, what those patients need, because I will mention now a few different kinds of therapies, all putting some coils or some liquid obstruction materials to treat those patients. Are we doing right or wrong? Because in many of the patients, maybe some of them even do not need some interventionist therapy, maybe. They may have some non-interventional therapies as well, but I think we have to redefine our research protocols. We have to redefine our way of approach to those patients in the long term to increase better quality data and to increase the evidence level of recommendations in future guidelines. We have the medical therapy, but mostly it is recommended, it is mainly focused on pain medicine or the hormonal therapies, which are mainly aimed to put the patient on a menopausal state. And we have historically surgical therapies, which we are not using many of them, but actually hysterosalpingo oophorectomy has been performed in the past for those patients. And I think which is a very over treatment for those patients. And we from my point of view, it is not different than any amputation, because you are just removing the organs. I think it is not good for making therapy for those patients. And we have embolization coils from many companies, very different one. I think as a standard therapy, which has been recommended from the previous guidelines, it is now as a standard therapy. You can combine it with foam sclerotherapy or the other liquid embolic agents, which I will show you. transjugular or transfemoral approach can be used, and especially in my practice, mainly I prefer transjugular approach, especially for the cannulation of the right-sided ovaric vein is much more easier if you come from the jugular vein because of its angle. And you can do it under local anesthesia and sedation. It can be do it walk-in, walk-out procedure, but sometimes you can need maybe one night hospitalization. Here are some my patients, so I don't want to go into details. So as a combination of foam sclerotherapy and coil embolization, you can treat the ovaric vein. And also this is the right-sided patients, and which I want to highlight is this, especially if you look at the previous part, this is the left side of the patients. First I treat, and later I treated the right side of the patients. Just I want to show you is these therapies are not fully innocent, because if you look at this coils here, and if you look at this nearly at 3 months, their positions has changed. So there is a risk of migration of coils from the point you, let's say, put in the first therapy. Especially just because of it, I don't want to focus on any brand, anything, but using pushable coils, I think can be difficult sometimes, because when you push the coil inside the vein, you have no chance to change its position or its place. Instead of pushable coils, I, let's say, prefer to use retrievable coils in my therapies. And as we all know that internal iliac vein is also an issue. Coils in the internal iliac vein position in my practice, I had one coil migration to pulmonary trunk. Its migration from the internal iliac veins is higher than the ovaric veins. That's why I think we should be careful while using those things. And we have also the, as I mentioned, liquid embolization agents. Ethylene vinyl alcohol copolymer is one of them, and also we can use glue on foam liquid embolization agents to treat those veins. And also, as we know that there are many branches, and if you just try to occlude all of them with coils, you need to have, I think, numerous coil numbers to occlude all that columns of ovaric vein. And combining the let's say, coil therapy with foam or the other type of liquid agents may increase the success of your therapy. As I also mentioned, no therapy is without adverse events. We can have all those type of complications. Although these are minor complications, we have to keep in mind and we have to deal with them. And we also have the embolization plugs, which can be used, but actually the sizing is very important when using embolization plug. If you use, let's say, downsized embolization plug, and if those plugs are migrated, then it's much more problems than the migration of the coils. So we have to keep in mind. And we can also use percutaneous sclerotherapy, especially it can be an alternative for the patients with no pelvic symptoms, and it can be combined with direct ligation of the exit points. And in many of the situations, those patients are really benefit from those type of therapy. And and you can just give the therapy instead of instances. And when the literature patterns, so this is a full low.
Recording in progress.
And also both can be a problem. So all of these sources, I think, should be evaluated very well to have a good success. And in the long term, when you look at the data from Dr. Whiteley's clinic, in this 6 to 8 years long-term follow-up, many of the patients are from let's say reflux-free state. And some of them, as we also, I think one of our colleagues mentioned very well, can have new type of insufficiencies in the long term. And there is only one study which shows us that also this, let's say, ethyl copolymer can be used as a salt therapy. Yes, it can be used. But for example, in my country, Turkey, this type of therapeutic options is not reimbursed. So you cannot use it as, which is a other type of problem. So we also, I think today there was a competition research presentation for male type of pelvic venous problems. When we think of pelvic venous disorders, we mainly focus of the problems in the female, but it is also an important pathology of the let's say male counterpart. So we have to also, I think, our patient group. And this is also a new study which I want to show you is as a sample, because for the bilateral ovaric vein and go through from the pelvic part to the other side and closing everything from left side can be a technique of choice, because sometimes really the cannulation of right ovaric vein can be a real problem. And as a conclusions, my colleagues, pelvic venous disorder is a, let's say, complex underdiagnosed cause of chronic pelvic pain, not only in female but also male patients, but especially for the diagnostic parts of the compression syndromes. I think we need some dynamic tests, and we shouldn't just rely on sonography. We need to use, I think, the IVUS, or we need to use dynamic duplex sonographies with flat and upright positions to judge especially the should be really careful, especially to exclude the compression syndrome, because in most of the time in any compression syndrome, the ovaric veins are the main collaterals. So to take the blood up, if you just coil such a collateral vein in a compression syndrome patient, we are not treating the patient, but we are not damaging it. So we are just increasing the complaints of the patients after such type of therapies. And also we have to be deal with the recurrences. But when we look at the any Gaia, or how to detect or how to deal with the recurrences. So I think we need to focus on also the recurrences of those patients, and maybe we have to set up some other type of, let's say, studies to deal with the recurrences, because we also don't know good patient-reported outcomes related with the pelvic pathologies. This is very important missing points of pelvic problems, because simply just asking, are you satisfied with the therapy? Yes or no, I think is not a good way of judging the patients. And we have many types of treatment options. We can use according to our repurposed system, but anyhow, doing something is better than doing nothing. But just focusing on interventional therapy, from my point of view, is not enough. So we have to also focus on non-interventional therapies like pelvic floor exercises, like other type of treatment pathologies before, I think, giving interventional therapy for those patients. Thank you for listening.
Thank you, Professor Delancey, for this informative talk about the total subject, which is the pelvic congestion syndrome. Is there any questions from our colleagues? Or you are just suspended because you are delay in time?
Yes, exactly. Again, thank you for invitation and being with you.
Thank you very much. We come for the next session, which is a symposium. Fakhri, who is the chairman of this conference. دكتور أحمد سالم سوري ما قريتش. دكتور سالم نقيل الأطباء القادم إن شاء الله. سوري. لا خالص. We can start the session with the talk from Svp. He will talk about the proper medical treatment of CVR.
Yes. شكرا دكتور أيمن. كل سنة وحضراتكم طيب. أيمن فخري على المشاركة في المؤتمر السنة دي. الحقيقة واحنا بنتكلم عن الدافلون، أنا ماركو عادل اسوشيت برودكت مانجر المسؤول عن الدافلون، واحنا بنتكلم عن الدافلون احنا مش بنتكلم على دواء، احنا بنتكلم على بارتنر حقيقي، ولينا اخبار جديده هنقولها عن الدافلون النهارده ان يور بارتنر از جيتنج بيتر. وده هيبقى ازاي؟ هيبقى باللونش اوف دافلون 1000. دافلون 1000 وزن اسبوع او اسبوعين هيكون موجود في الماركت، والموضوع بيتخطى انه بدل ما كنا بندي البيشنت قرصين في اليوم هيبقوا قرص واحد بس. موضوع عباره عن ماكسيمم ادهرنس هيؤدي بالبيشنت الماكسيمم افيكاسي. زي ما حضراتكم عارفين البيشنت از بولي ميديكيتد، البيشنت بياخد ادويه كتير جدا، عنده التندنسي انه يوقف العلاج طالما هو مش كومبلاينت معاه. وبالتالي والاول مره هيكون عند حضراتكم مش بس حضراتكم فيديو مدته نص من الدافلون.
Are you ready to discover the innovative factory secrets of the venoactive drug leader? Daflon comes from a natural origin. It all starts with small, immature oranges. They are picked right by the sun for production.
Recording in progress.
Provides mainly diosmin, but also hesperidin, isorhoiflin, linarin, and diosmitin. This results in high-quality purified flavonoid fraction. And that's not all. The second secret is Daflon's unique composition. Daflon stands out thanks to the synergistic effect of its 5 components, leading to a better absorption compared to other drugs using giant particles. The active ingredient is then transported to production sites where the tablets are made, and the 86 million boxes are packed to treat 28. You are now aware of Daflon's factory secrets, which make the difference. An innovative technical process, a unique composition, and a high-quality micronization. All this results in the high-quality and trusted partner to treat your patients suffering from 2 serious diseases.
زي ما حضراتكم شفتم في الفيديو ده احنا بنتكلم في 3 فروقات دلوقتي مش فارقين، بس الفرق الاولاني هو اليونيك مايكرونايزيشن 1.79 ده حجم البارتيكل، وده بيدي 30% زياده نتيجه ان الابسوربشن بيكون اقوى بكتير. هم شفتوا من الدامين والدايزبيتين وايزوفلافين والهسبريدين، ودول اللي بيبقى MPFF، وده اللي يمكن النهارده ذكر مره او مرتين اثناء السيشنز. الحاجه الثالثه بقى وهي انه ماكسيمم ادهرنس وماكسيمم افيكاسي، ان كل ده البيشنت. يمكن من الكلمات اللي اتكررت اثناء السيشنز كتير النهارده ان احنا we treat the patient. النهارده البين والهيفنس والإديمة، especially لو هو شغله بيوقفه لمده طويل وعايز يستريح في اسرع وقت ممكن من البين والهيفنس والاديمه، ولكن حضرتك مش عايز له كده، بس حضرتك عايز له الحته اللي هو مش شايفها. البين والهيفنس والاديمه هي التيب اوف ذا ايسبرج، لكن من تحت فيها في فينس ريفلكس وفي فين انفلاميشن واخد البيشنت ده ناحيه irreversible complications وانس حصل الفالف فين دامج، وهنا بيكون دور الدافلون 1000 بالقرص واحد بس في اليوم. من ناحيه البين اللي بيشتكي منه البيشنت بتحسن بيوصل 71% في خلال 8 اسابيع، وده زي ما حضراتكم شايفين بيكون تحسن تدريجي بيبتدي يحس بيه البيشنت على طول اول ما يبدا العلاج. النقطه الثانيه الاديمه، ودي يمكن شكوى يعني عامة وكبيرة جدا. الإديمة بتقل بحدود 800 مللي في محيط الأنكل في خلال 6 أسابيع. 800 مللي دول يعني حدود كوبايتين مية، يعني حدود مقاس في الشوز، فده بيساعد البيشنت ان هو يكمل مده العلاج اللي هي 3 شهور. لكن اللي كان لافت جدا كمان للنظر ان ده كان اكتر 4 اضعاف من اي دايزمين تاني موجود في الماركت. فدي نقطه من النقط المهمه جدا اللي حابين نسيبها مع حضراتكم. طب وات اباوت الجزء بقى اللي ما كانش باين، او الجزء اللي فيه الانفلاميشن والجزء اللي كان فيه الكلام ده كله، ايه اللي هيحصل فيه؟ الحقيقه ان ريسنت داتا على الدافلون كانت بتتكلم على المايكرو فينوس ريفلكس للبيشنت السي 0 والسي 1، والحقيقه انه في خلال 3 شهور اتحسن المايكرو فينوس ريفلكس ب 48% عند البيشنتس دول، وده طبعا بيلعب دور كبير جدا في الايرلي دايجنوزس. يعني يا بخت البيشنت اللي بيجي اول حد يستشيره هو حضراتكم اللي شايفين البروسيس دي ماشيه ازاي. طب لو البيشنت جه بقى في سي 2 وسي 3 اللي هي اخر مرحله قبل ما يحصل فالف فين دامج، هي ان برضه ريسنت داتا بتتكلم على ازاي ان الدافلون بيقلل الفينوس ريفلكس، وهنا كان قياس الفينوس ريفيلنج تايم في خلال شهر واحد بس اتحسن من 15.5 ل 18.3 وايل ان النورمال 20 سكند. وده دليل ان النهارده بالدافلون 1000 بقرص واحد بس في اليوم حضرتك هتوقف الديزيز بروجريشن عند البيشنت ده. أنا حقيقي عايز أختم كلامي بريسنت برضه جايد لاينز الانترناشونال أنجيولوجي في 2018 ادلت الدافلون باي نيم زي ما حضراتكم شايفين 9 سترونج ريكومنديشن على كل الشكاوى اللي ممكن البيشنت يشتكي منها وكل السيمتومز، سواء كان البين، الهيفنس، الإديمة، الفيلينج اوف سويلنج والفانكشنال ديسكomfort، الكرامبس والليج ريدنس والسكين تشينجز، والاول مره كمان كانت الكواليتي اوف لايف موجوده في الحته دي، وده ماتشت جدا مع شكوى البيشنت في العياده اللي بيجي يقول انا مش قادر انزل الشغل انا، وطبعا دي تاثير مادي عليه. اخيرا كمان انه الجايد لاينز نفسها على مستوى المود اوف اكشن ادت الدافلون زي ما حضراتكم شايفين الام بي اف اف هو الوحيد اللي واخد سترونج ريكومنديشن على كل المود اوف اكشن بتاعه، ايفن حتى اي دايزمين تاني كان ويزاوت اني ريكومنديشن، وايفن حتى كمان كان قدام الكالسيوم ديبوزيليت، وكان ريماركت جدا ان الفينوس فالف اند وول دامج بيتعطل بالدافلون بس مش باي حاجه تانية موجوده في الماركت. زي ما قلت لحضراتكم من النهارده يبقى عندنا الرابيد الباورفول السمبل دوز بقرص واحد بس في اليوم لمده 3 شهور من الدافلون 1000 عشان نقدر نوصل للماكسيمم اديرنس والماكسيمم افيكاسي للبيشنتس دول. اخر حاجه عايز اقولها انه الدواء هيكون متوفر في الماركت حدود من اسبوع لاسبوعين كمان عند كل الموزعين وعند كل الصيادله. الدافلون 1000 هيكون السعر بتاعه هو 30 قرص، هيكون السعر بتاعه وهو سلايتلي اقل من سعر البتين الدافلون 500، وده طبعا في الظروف اللي احنا فيها دلوقتي دي حاجه يعني واضحه جدا مهمه بالنسبه للبيشنت. 3 شويت. انا ما خدتش كل الوقت علشان خاطر انا حابب لو في اي حد عنده اي سؤال او اي استفسار على الخطوه المهمه دي للدافلون 1000، وانا تاني بشكر حضراتكم جدا. ميرسي.
شكرا جزيلا. هو بس سؤال يعني اكيد بيتبادر للاذهان، يعني دلوقتي الدفن عند الناس لما يبقى 1000 متوقع انها تزيد، فهل انتوا عملتوا حاجه؟
هو حقيقي الجاستريك اوبست هي حاجه من الحاجات اللي ممكن بعض البيشنت يشتكوا منها دكتور ايمن فعلا، بس احنا برضو بنحب دايما نقول انه البيشنت ده ممكن يكون بولي ميديكيتد بياخد ادويه تانية كتير، ايفن سبيشال ان احنا هنا بنتكلم على بين، فهو ممكن يكون بياخد بعض المسكنات اللي ممكن تكون مسمعه معاه في موضوع الجاستريك اوبست. وايل انه ايفن حتى بالنسبه للدافلون 1000 هو البيشنت هنا لما هياخده وانس ديلي فاحتماليه ايفن حتى انه يحصل له اي حاجه من ناحيه الدافلون هتقل كمان لاقل من النص، فده هيفرق جدا مع البيشنت، وده هيتساب لتجربه حضراتكم للدوز ال1000 او الوانس ديلي.
يعني لا هو الدفلون فعلا بيحصل مع جاستريك ابسط مع بعض المرضى، ولا برضه ناخد راي الناس يعني
ده غير ان
فهل ده
فكرتني بحاجه.
هل ده هيزيد؟ ما هو بعد الاكل برضه مش كل المرضى، خلينا نقول انه في some patients بتسفر من الدفلون، وانا في الحقيقه ما بصرش عليه يعني.
اوكي فهمت.
دكتور عادل كان عايز يكومنت.
شكرا بعد اذنك.
We'll move to the second talk from Combatech.
Dear professors and doctors, thank you for allowing us to be part of this event. Start by saying about the wounds, their initiation, and have found them to turn to be a chronic wounds. Today, we are going to talk about a solution, not just a dressing. It's a solution that will help you through your journey and help your patient to get the best treatment that is ever present, to make sure that whatever the challenge that your patient is facing, now you have a dressing that can address it in the right manner. So when we are talking about the barriers that we can face during the wound healing process, and actually when we were having our workshop, we were talking about that there are local factors and systemic factors. If we are pointing out to the systemic factors, because without the systemic factor, we can never have the perfect healing journey. So the introduction, if you are having poor diet, if you are having obesity, if you're having diabetes, those are certain issues that you have to handle before just looking to your wound. Which are the edema infection, especially the biofilm, and I'm sure that most of you, if not all, are aware of the biofilm concept and know how it directly influences the wound healing process. The ischemia, the low oxygen level, and of course, the necrosis and slough that we may find in these wounds. But if we say that we are having three main issues that we want to address, and you can find we are having some villains, most of you are familiar with them now. They are villains, but they are so cute because if you treat them in the right manner, they will not be villains anymore. We'll find that the extents that we are looking at. Why we're saying that can be the root changes from the local to systemic, and the biofilm, we are going to focus more on this problem and give it its due care in this session. We're going to start by the biofilm. Simply, the biofilm are colonies that are engulfing itself by slimy layer to protect itself from any other antimicrobial that is present. At this part, the problem is not in the microorganism only. You don't need something to kill the microorganism only, but you need something also to penetrate through the biofilm. There is a very, very, very common saying about the biofilm that if you did not brush your teeth for a while, you'll find a slimy appearance in your teeth, right? If it has been like from the morning and we did not brush our teeth, we can do like this. Check our teeth by our tongue. It's a bit slimy. Is it? It's a bit slimy. You know why? Because in this stained photo here, you can find that this is a stained biofilm that shows that the biofilm is easily formed. And this happens if you leave the place which is able to anchor the microorganism for over 2 or 3 hours. So simply how it happens, how does the biofilm form? It started by finding a surface to attach to. In our case here, it will be the womb bed, and then making the colonies and increasing in the size, and then increasing this size and engulfing itself by this slime layer. The true issue with the biofilm that the new formed colonies here, if you see here in this photo, the new formed colonies are biofilm colonies. So by the regular means of mechanical debridement or sharp debridement, it will not be enough, because if you lift even a small remnant part of this biofilm, it will be able to make new biofilm colonies as well. This is a beautiful photo with the biofilm under the electron microscope, which is the gold standard of identification of the biofilm. It started by the planktonic form of bacteria, and then it aggregates together. Part by part, it loses its morphological appearance. And this happens because the slime that engulfs itself with it is completely covering it. The problem with the biofilm, again, that it prevents any outsider antimicrobials from acting. It turns to be like a rug at the end of the process. But we want to try to visually is more likely by the glowy appearance, this one, that you can find on your wound while you are having low-grade inflammatory reaction in the sites. So why biofilm is a problem? Because it's contributing to almost 30% of the chronic wound retardation, and from a wound that has high tendency to heal into something with a foreign body that does not allow it to heal. If you look at these photos, we find some dehisced granulation tissue formed. We will find some other types of colonies here. And all of these photos shows to you that there is a chronic problem that is preventing from wound from closure. And this is simply because it's a suspected biofilm that we just saw in the electron microscope. Again, this is a drawing that shows film is physically present. When we're having the biofilm, it has its toxins getting in. And if you use just antimicrobials, if you use just antibiotic at this point, it may be able to work through this tissue, but it will not be able to handle the biofilm itself. So simply, when we're talking about the tooth part, if you brush your teeth, do you still have this slimy feeling? No, you will lose it. So the first and most important part when dealing with the biofilm, that it should be mechanically removed. This is the most important part. But you will find at this point that there is another problem, which is that even if you are mechanically removing it, a small remnant part is enough to form new biofilm colonies and start the process. So that will be actively dissolving the remnants of the biofilm and preventing its reformation again. Another barrier that we have is the infrared color of the wound happens when we are having clean wound. And has no microorganisms at all. They all have microorganisms as contamination. But are they in enough load of making it a pathogen form of microorganism or not? This is the main size and shape of the microorganism will be planktonic, which is not a once they found the surface, colonization, and then it will be luckily for
Recording in progress.
And the glossy appearance. This is called the critical colonization phase. Your body here is still trying to defend, so it's not systemic yet, and you can locally deal with it in the perfect manner. At the last stage here, now this is systemic one. It's not just confined to the local one. You will find that the patient is having high temperature. You'll find also that the patient in this phase also tried maybe sepsis and vomiting. But if you look at the microbic part, you will find that the microorganism has formed already biofilm colony, and it's able to make new biofilm colonies. And this is important of not just removing it mechanically, but also using something that will not allow the biofilm to be reforming again. The causes infection is very high, including that the patient is there and leaving more than once, and is occupying your time and your staff. The last villain that I'm talking about is the exudate. And as we mentioned, the exudate can be beneficial at the right manner as it helps the fibroblast to travel in the right manner, and it helps the fibromesh to be formed. Not only that, it can be a source of nutrition to the wound itself and help it to heal. Now, if you look at this part, you will find that this one is macerated skin, which is the peri-wound skin. And as all of you notice, the wound is healing from the peripheries to the center. So we need healthy peri-wound skin in order for this to heal in the right manner. Introducing you the solution from Convatec. Simply the solution here that three villains are present, the exudate, the infection and the biofilm, which is our main focus in this session, we're having two powerful technologies working together. One of them is Ag+, and when we're saying Ag+, we are not saying ionic silver only. No, we are saying ionic silver and antimicrobial with plus. Plus is the antibiofilm material that penetrates through the biofilm and allow it to kill the microorganism, and the hydrofiber, which is the active ingredient of the Aquacel. And there is no other company, not in the whole world, that's offering you this combination. They don't have hydrofiber, they don't have antibiofilm. Even if they have the plus sign, it's for ionic, not for the antibiofilm. So both of them is one family, which is the Aquacel Ag+ Extra. As we mentioned, the plus technology is able to disrupt and break the biofilm and then kill the microorganism. And the last part, it's reformation. Why? Because it's an organism and they're preventing it from forming new biofilm colonies again. So if you are saying about the hydrofiber technology itself in the Aquacel, we will find it that it allows the fluids and the exudate and the other harmful components to be getting inside the fibers itself. And this is why it does not cause any lateral wetting. Your patient will never face maceration. You will have healthy peri-wound skin to heal your wound from the preface to the center. And then it makes micro-contouring. The micro-contouring simply that no one is as smooth as this surface. It always has its ups and downs. Micro-contouring means that when this fiber swells, it takes the exact morphological shape of the wound, preventing any dead spaces which harbor the microorganisms to live in. And then it responds. It responds by having sustained release of the antimicrobial, which is the ionic silver, and sustained release of the plus technology, which is the anti-biofilm technology, along with the soothing effect it provides to your wound. How it looks like? It looks like two sheets, stronger stitched together. This is Ag+ Extra. It has different sizes, 5x5, 10x10, and 15x15. And for the deep wounds or tunneling wounds, you can use the rope, which is 2 centimeters by 45 centimeters. To prove to you that the biofilm is a true problem, because we did not make it with anything except our own cells. We made it with our cells to show that the old form, which was named Aquacel AG only, without the plus technology, was unable to kill the MRSA in its biofilm colony form. While the new form, which is the Ag+ technology, was able to completely eradicate the MRSA colonies in its biofilm form. So thank you for that. And I want to close with this study. It was non-comparative 42 chronic venous ulcers, since we are here talking to most of you, seeing mostly the venous leg ulcers. It completely reduced 54% all of the wounds, the infected and non-infected, while the infected one, which were more suspectedly having biofilm, it reduced it by 70%. Talk about effectiveness, talk about Aquacel Ag+ Extra. Thank you for that. And I want to tell you in the last part that any exuding wound that you are having glossy appearance to it, your first choice as a primary dressing can be Aquacel Ag+ Extra, with full confidence that it will not only eradicate the microorganism presence, but it will also eradicate the presence of the biofilm. It's available also in the raw form. When you are doing it to a deep wound, only pack 80%, because once it absorbs the fluids that is present, specifically the exudate, it turns to swell. So only pack 80% and leave 2 centimeters outside to pull it. Thank you for your time, and I'm here to answer
the frequency of dressing.
Thank you, sir, for this question. The company recommendation is maximum of 7 days, but as per your clinical experience, if you find the one that is highly exuding, you may need to change it like after 3 or 4 days, accordingly as per your clinical experience. But if the amount of exudate is adequate, we could leave it up to 7 days.
And about the selection of the type of dressing?
Yes, sir. The company itself offers a wide range of dressing. Today, I only talked about one because I know that venous leg ulcers is a big problem, and sometimes you need to do a dressing under compression. So I talked about a primary dressing, which is the Aquacel Ag+ Extra. This one can be used with any exuding wounds with suspected infection or suspected biofilm or biofilm. We're having another range of completely occlusive dressing, like the Duoderm range, and we are having another range for bleeding wound, like the Caltostat range. If any of you are interested, you are more than welcome to our booth. Thank
Thanks.
you.
Any question?
It has been my pleasure.
دكتور أيمن تفضل.
Pleasure to ask for the evaluation of the course.
Recording in progress.
Dr. Adel Ilham Award. The competition were between three competitors. Maria Shaldian from Russia, Dr. Mina Max, and Dr. Mahad Goma from Egypt. Actually, after assessing their presentations, and the judges put the scoring each one honestly, we collect and some the scoring for each of them. Fortunately enough, actually, the three competitor was around to be the same level in each items. The winner, as usual, Dr. Maria Sheldon from Russia. Congrats, and I hope for her to keep going. Congrats, she around, she is with us. So doesn't matter to declare the second or third. Actually, the second one, Dr. Mina Max, and then Dr. Muhammad. The difference between the competitor, just a few degrees. So good luck. See you next year, hopefully. Thank you.
Now, before I go, I would like to make some evaluation of the course. The course started today for 2 sessions with about 8 hours credit by International Union of Angiology. We have about 60 fellows join the course. Also, we have 8 speakers from everywhere in the world, from Australia, Europe, Africa, Asia. Promise today, we promise those who attend the full course will get the certificate, and we have already know who will attend the full course. Also, we promise those who attend the full course with 3 books, vascular trauma and sclerotherapy. 3 original books, original PDF will send to those who attend the full course, will send to their email. For Amr Abdurrahim to give his input, what we aim to do in the next winter course.
First of all, I'd like to thank Professor Ayman Fakhri for such a tremendous gathering in the Egyptian Business Forum. I think the next time we could give more efforts for workshops concerning different aspects of venous procedures, venous treatment in general. Also have to make a communication, more communications with different associations to gather up or to collaborate together for a proper research work, gathering the Venus family together. So raising the research work and raising the more and more workshops in
Recording in progress.
I'd like to ask Professor Ayman. I'm done.
Thank you, Dr. Ayman. And now we have to move to the next session. And thank you for your attention. Thank you.
Then should be the debate session, and I see I think brought his weapons and they're ready to fight. May I ask up the Professor Adel? These our chairpersons, and I am the moderator of this session. Now I am happy to introduce the first debate. The debate says 0 point at Evelyn is okay. Thank you, Cavezzi. Professor Cavezzi will join us for the session as a chairperson. The point of debate: ablation of the great saphenous vein during Evelyn at 0 point. With the motion, Professor Chris Ragg. Against the motion, Professor Nader Hamad. Chris, the mic is yours.
Hello, dear friends over there in Cairo. I'm happy to see you at least on screen. And I ask you if you will play the video I sent in this morning, or would you like me to share my presentation from my desk?
We'll play the video. Yes.
Hello, dear friends in Egypt. This recording is exclusively for the Egyptian Venus Forum 2022. I'm proud to present on endovenous ablation of the saphenofemoral juncture. I have no disclosures. You will know from my background that personally I'm fighting for the evolution in venous therapy, in particular about preferring vein healing to vein killing. And I do this in collaboration with a non-profit organization called the Leading Vein Clinics of the World. Together we are doing lots of research to improve all our current strategy, and I hope you will enjoy this talk. When we're talking about GSV ablation, we are well aware that thermal ablation has the danger of creating a heat. So many of us prefer to start the ablation below the epigastric vein level. When we do venous gluing, of course, we have to avoid the propagation of glue to the deep venous system, and that's the reason why all the manufacturers recommend to keep some distance of 2 to 7 centimeters to the junction. And foam ablation, we are aware that there is always the danger of foam particles or even larger amounts escaping through the saphenous junction, creating deep vein thrombosis, and that's another reason to maybe keep some distance to the junctional level. I would like now to introduce you to some general rules of optimal endovenous therapy, and it starts with the determination of the true origin of the disease, meaning the exact valvular status concerning closure defects, damage on certain parts of the leaflets, and so on. Second, we need to know the status of the different valves involved in the region of interest. Third, we should not stop our examination exactly in the region of interest, but go a little further to check the surrounding to estimate potential hemodynamic interactions. The rest of it is therapy. I would like to stress the necessity to establish a laminar flow for the prevention of recurrences. This illustration, starting with the congenital embryonic valvular lesions, half of our kids already have them in different quantity and quality. Years later, we observe pressure-induced valvular decompensations, and finally, even some years later, there's a third kind of, in this case, valvular destruction. Most procedures starting with the accumulation of blood cell accumulates in the valvular region. So any one of these three mechanisms could be relevant for the disease of the saphenofemoral junction. And the first letter of these mechanisms, embryonic, pressure-induced, stasis-related, resulted in the idea of giving EPS name to this brand new classification of valvular lesions. Now, if pressure-induced damage should be present in the pre-terminal or terminal valve, you have to think about the reason for that. And most probably, it's if it's asymmetric and it's just related to one side, there might be the situation of missing or diseased iliacofemoral valves. So you will not be able to provide a real solution. You cannot heal the origin of the disease being venous hypertonus. So in this case, I think it's highly important to protect all the other branches of the femoral junction from this hypertension. In other cases, it might be different. If you have congenital or acquired lesions by stasis, there is no other reason around, and your treatment of very lesion location might properly fix the problem. So we have to go for the real origin of the disease. Second, of course, we, as a standard, will evaluate all the branches around the junction for reflux or for any hemodynamic abnormalities. Many of these factors are quite new, as we should also look for local valves which are not yet decompensated or disrupted, but show some signs of pre-reflux changes. So we should take that also into account. To prevent early recurrences. In particular, I would like to emphasize value of this publication among many other mechanisms of damage the femoral was about leaving a stump or not. So if there is increased femoral hypertension, it's very probable that as this cause will persist, we have a higher incidence of SFJ recurrences, and in particular AHGSV insufficiency from hypertension by doing closure from femoral level. So I would say that all failures, recurrences, and complications occurring around the SFJ are due to suboptimal analysis or suboptimal techniques.
Recording in progress.
It isn't. It's just, in the best case, a sphenectomy. And group B, starting ablation below the epigastric vein level. And you can see that by estimation of the anatomy, by starting at femoral level, almost every case had the AHGSV well covered. And when doing the laser below epigastric level, just very few cases had the entry of the AHGSV properly covered. And so it's not surprising that after 2 years, we see a low rate of AHGSV, a newly appearing disease, while in group B, when laser started, which had the AHGSV covered, we see a 5-fold increased rate of newly onset AHGSV insufficiency. So there are many reasons to differentiate the cases and the situation. And if you think there is any reason for pressure protection or prevention of AHGSV disease, if it's not diseased at the time you do your GSV therapy, I can really recommend to start from femoral level and to take care to properly cover all the space to the venous femoral wall with your tumescent fluid and do a perfect compression of your target vein. And in this case, you will not see any complications, and in particular, no ear hit. These final pictures show typical situations after different techniques of ablation, and of course, the cases with a longer or shorter stump do not represent laminar flow, while a proper closure at femoral level would do so. And of course, this is highly favorable in terms of prevention of recurrences. If you cannot achieve laminar flow with the means you have at hand, you might consider to add some hyaluronic gel to fix your target vessels to the desired size. And this is a new method and actually a topic of a different talk another time, another year, to show you how we can influence recurrence rates by this additional optional tiny, short, clever treatment. So I come to the conclusions, and let me state that laser ablation of the GSV from femoral level is highly effective in preventing future AGSV or other branches reflux compared to modalities leaving any stumps. This was known and true for surgery. It seems slightly less important for the intravenous therapy, as we do not apply that much local force and there's not that much damage, but the principle remains, as any local pressure will have some propagation to the local branches. Second, a procedure like this will prevent recurrences, in particular in case of increased iliacofemoral pressure. That makes quite sense. Third, the technique I showed to you, it's very simple, very safe, and very effective to prevent any complications like ED. And third, we should not just watch the local SFJ anatomy, but extend our examination at least to the iliacofemoral and AHSV valves to check for the real optimal strategy. So thank you very much for listening. It was a big fun to present, and I hope you have also a big fun to listen to this and the following talks and go for exciting discussions. Thanks a lot.
Thank you, Rag, for this elegant presentation. Please wait with us. Professor Nader will make his presentation, and we will allow 2 questions for each competitor. Then we will get the voting for with the motion and against the motion. Stay with us, Rag.
Hello, good evening, and thank you very much for staying with us for this late session. And I congratulate Professor Dr. Rag for his elegant presentation. And unfortunately, I have to contradict what he said. This actually debate is not about is it useful to treat the accessory, the anterior accessory great branch tributary of the great saphenous vein or not. It's about how do you treat it. So I would recommend continue as a hero, say no for 0. So remember the Hippocratic oath, first do not harm. And the history actually of resecting of great saphenous vein, I don't want to go through the history because of sake of time, but it was the first idea to remove part or a segment of the vein to treat varicose veins. And this is not a new idea. And there's something actually mentioned in the old papyrus papers and in the Arabic old medical scholars that actually they were removing the varicose veins in the past. In 1916, Homans in Boston started the radical operation for severe varicose vein with venous ulcer, including crossectomy, stripping of the great saphenous and ulcer excision. And since then, the recurrence remained an unsolved issue. And I will go with what Professor Dr. Frolini mentioned, that actually the term recurrence, when we are talking about varicose vein, might be a wrong term to use, because it is a chronic disease like diabetes and hypertension. And if something started to be clinically evident, this doesn't mean that the disease disappeared for a period of time and then it appeared again. Actually, the disease is still there, whatever we are doing for the patient. So in 1987, Glass introduced the new vascularization as the main cause of recurrence. Endovenous laser therapy was firstly introduced in 1998 by Spanish phlebotomist Carlos Bon. There are conflict of claims, and different authors claim that they have used other techniques for thermal ablation of the varicose veins. And the technique, as actually advised by all the companies, mentioned that replace dilator with catheter and advance to the saphenofemoral junction, replace the guide wire with the laser fiber using the ultrasound in longitudinal view, advance the laser tip until 2 centimeters distal to the saphenofemoral junction, ensure that the IEV is visualized. So this is their own recommendation. All laser companies recommended that. Start thermal ablation 2 centimeter distal to the saphenofemoral junction, regardless to type of fibers and laser wavelength. We know that actually there are a lot of advances that happened in laser production and manufacturing as regard laser length and type of fibers, and they didn't change this IFU. For varicosis in great saphenous vein or short saphenous vein, endovenous techniques have largely replaced traditional surgical stripping and vein ligation. And this is because of the complication of surgical stripping, which include extensive ecchymosis, scarring, hematoma, lymphocyl infection, nerve injury, and DVT. While actually recent research had showed that DVT is not really different from surgery to radiofrequency, for example. Initially, bare tip laser fibers emitting laser light with relatively low wavelength from 810 to 1000 were used. And recently, we have higher laser wavelength, 13 to 1900s. And the fiber tip has different configuration to minimize the postoperative inflammatory pain, bruising, and endothermal heat-induced thrombosis. And these are the different tips of the laser that are used nowadays. But as regard to recurrence, surgical stripping was associated with high recurrence, up to 50% in patients in 5 years, most often as a result of incomplete phlebectomy, persistent venous reflux, or neovascularization. But since the recurrence was an issue, and since the introduction of the laser, there were hundreds. I will not go through all these studies, and some of them are randomized controlled trials. Many of them were meta-analysis. And all these studies in different, and even in the old era of the laser, they studied laser versus surgical intervention versus stripping and high ligation. And actually, most of these studies included patients who were treated in the IFU, which is 2 centimeters away from the saphenofemoral junction. And still, the results were very satisfactory in favor of laser in comparison to the surgical stripping and high ligation. So compared with high ligation stripping, most studies reported no statistically significant difference in varicose vein recurrence. And we have to remember this very, very important. It's totally different thing when we are commenting on recurrence as a clinical scenario in comparison to radiological finding. And this actually was very obvious when we talked about a recurrence in following laser and radiofrequency, that most of these recurrences were not really clinically relevant. And actually the quality of life of patient when they assessed were superior in comparison to surgery. So not every recurrence or a long stump will be clinically relevant and will upset the patient. So according to 2 systematic reviews and meta-analyses, recanalization was the most common cause of recurrence after EVLA, whereas neovascularization was more frequent in the high ligation and stripping. And we know from the past, actually, the crossectomy didn't improve the outcome of endovenous laser. I mean the surgical crossectomy. The recurrence in the surgical group, as you can see, is followed actually by neovascularization inside the fibrous tissue. And you can see this is the image of the small trabecular vein after the high ligation. And after a few years, this is what will develop. And this is totally different in the thermal ablation era. But if you go to the European Society guidelines, you'll find actually the recurrence actually is not a one-factor problem. Again, I emphasize that actually the term recurrence shouldn't be used, but this is what we are used to say about radiological or clinical appearance of the varicose vein post-procedure. But taking in consideration all these causes, it's very difficult for me to ignore all these causes and just try to target one thing against the instruction for use of the company, which is the accessory anterior tributary of the great saphenous. So there are many articles talked about the fate of tributaries after the thermal ablation. And the saphenofemoral junction tributaries are usually left untreated at the time of endovenous ablation of axial vein. And literature search and analysis of evidence reveal that the junctional tributaries are one of the commonest, ranges between 8 to 31% cause of recurrence following endovenous ablation of the axial veins. So should we treat them? recurrence of varicose veins after endovenous ablation of the great saphenous in randomized trial. And again, recanalization was the most common cause of recurrence, about 32%, followed by the development of anterior accessory saphenous vein. So actually, recanalization was actually double the possibility of recurrence due to anterior accessory saphenous vein incompetence, and incompetent calf perforating veins were an infrequent cause 7%. So should we ablate the anterior accessory origin? Pushing the boundaries, there were many publications about flush closure of the saphenofemoral junction with laser. And the conclusion that actually they have mentioned is flush closure and short stomp gave better early results than the formerly recommended technique, which is 2 centimeters away from the saphenofemoral junction. There is not a higher risk of complication. They are talking about the endovenous thermal thrombosis if the junction is occluded flush with the femoral vein. But ultrasound findings in 33 limbs, if we go for analysis of these studies, 39.7 flush closure of the saphenofemoral junction was